Hello. So I'm a mental health nurse and I work on the mother and baby unit. So an MBU is it's a specialist inpatient unit for women who have mental health difficulties during pregnancy or after the birth of their child. So before MBUs existed, if you became mentally unwell and you needed hospital placement, you were separated from baby and you would go onto an acute ward. So the idea about a mother and baby unit is keeping mum and baby together. There is only, I think, like 19 MBUs across the country, maybe not even that many, but there's not as many MBUs as there are acute wards. So the staff, the idea is they nurture and support the mother and infant relationship at the same time as we are offering mums treatment for the mental illness. So we can admit mums late in pregnancy. So that's we take from like 28 weeks pregnant, and they can stay until baby is up to a year. And we don't take any over a year. It's really different to an acute ward. So although we are an acute ward, it has a really different feel. So we're an 8-bedded unit, and we have, I suppose, fewer restrictions to some of the other wards because we have babies on the ward. The way we look at risk and way we manage risk is slightly different. We work really closely with the community perinatal mental health teams and maternity services and health visitors. We work alongside the Lotus team and the teams at the NNN. For any of our mums, if they've got those kind of teams involved, we will work with them throughout their journey. The mums have their own bedrooms, they have an ensuite, and they have a cot or a Moses basket in their room. So the idea is that they're kept together throughout kind of their time on the ward. So I thought it would be helpful just to do a little kind of day in the life, I suppose, of a nurse on a mother and baby unit, because it can look different. So I kind of just spent some time writing down some of the things that that we do. So we have handover, and we have that 3 times a day. So we have handover in the morning, we have it at lunchtime when we have our late shift come on, and we have it again at night when our night shift comes on. We need to complete safe care, which is when we look at staffing levels. So we have a little look at what staff we've got and use that alongside what things that we need to be offering during the day. So if we've got any one-to-one observations, if we've got any groups running, if we've got any additional obs, ward rounds, things like that. So we just have a look at what tasks we've got and what staff we've got, and make sure that we've got enough staff and the right staff mix to be able to manage the ward safely. We also then need to do the allocation of staff. So again, if we've got any one-to-ones, we need to think about who's best suited to do that. So any staff looking after babies on the ward. So the idea is mums do most of the care, but sometimes due to risk or poor mental illness, we will support mums and we will be on a one-to-one with the baby, and that means that we need to have staff who have baby competencies, so understand kind of how to make a bottle, to change nappies, how to soothe babies, developmentally have an understanding of their needs, so we can make sure that they are supporting mum in the right way as well. So we will always try to be the least restrictive and empower mums to carry out the care. So we would do medication rounds, so we do the meds round in the morning. Any medication that is not available or running low, it's then up to us to make sure that we order that. Anybody who's going on leave or being discharged, we need to make sure during that medication time that has been ordered. We also have a daily task list, so anything that's outstanding that needs to happen for those patients, we would allocate accordingly. So if people need their rights read, if they need physical observations taken, we'll look at what staff we've got and allocate that again through the day. We use Teams to do that, so it just means that we can kind of update, keep an update on that. Care planning, risk assessments, we update those weekly, or if any significant events happen, that we need to make sure that they are up to date. ward round. So our mums will have a weekly ward round, and they run on a couple of different days. So we make sure that we're attending in there, make sure that we can share our general nursing report, but also that the mum's voice is being heard. So we kind of act as an advocate on their behalf as well. Offer supervision to colleagues, so line management or clinical supervision. We offer daily one-to-ones to patients, so again, just to make sure they're doing okay, if there's anything they need. They can be planned, but they can also be sporadic, depending on how the day goes and how people are feeling. We offer carer support, so to families and partners. We offer to signpost for like carers assessments or wellbeing referrals. So it's helpful to know that if a partner their partner is under perinatal mental health services, that they can have a referral made to wellbeing services, and they will be seen as a priority, because we know that patients or partners of patients under the perinatal service do need additional support. We carry out aspects of baby care at times and run groups. So our normal staffing levels are 6 on the early, 6 on the late, and 4 on the night, and that allows for us to have 1 or 2 one-to-ones within our numbers before we need to get extra staff.